Today we're going to be having a conversation on sleep with Dr. Sanjay Bafna, who is a pediatric pulmonologist and a pediatric sleep specialist. And myself, Dr. Aarti Kamat, I'm a pediatric sleep specialist with a special interest in adolescent health. So why are we talking about sleep? On an average, children till the age of 2 years, they spend 9,500 hours sleeping as opposed to 8,000 hours staying up. Between the age of 2 to 5 is 50-50, and from late childhood to adolescence is around 40%. So do we really need to sleep so much? So Dr. Bafna, why is sleep so important for us all? And is sleep needs different with ages?
Yeah, so basically, thank you very much, Aarti, and good afternoon, everyone. So, as Aarti has pointed out, sleep is something which is very physiological and it's a normal bodily function. Then, why are we discussing sleep? So, sleep is basically almost 1/3 of your life you are spending time in sleep. So there has to be some purpose, and most of the time when we sleep, I think what happens during two types of sleeps, they are there. So one sleep, the non-REM sleep, is important for your physical rest. During that time your body gets rejuvenated, there is a metabolic function which goes down, and then physically you are becoming more there's some rest which is required. Whereas in other part of the or other half of the sleep, your mind gets rejuvenated. So that is also important for your cognition, for memories, consolidation, whatever has gone during the day, all that gets consolidated. That's the reason probably we sleep, and that is the function of sleep.
So as you see, sleeping is not actually sleeping. Sleeping is when the body does a lot of work, technically. So sir, do sleep needs change with age from infancy to adolescence?
Yeah, so the duration of sleep, you mean to say, as already pointed out, that the duration of sleep decreases over a period of time. We all say they're sleeping like a baby. What do that mean is, in almost 20 hours or 18 to 20 hours the newborn baby would sleep. But then gradually over a period of time that need goes down, and therefore the duration goes down gradually. And by the time the child is 5 years to 12 years, almost 10 hours or 9 to 10 hours sleep should be enough. For an adolescent or for an adult, around 8 hours of average sleep is still required.
So what do you mean by good sleep?
Yeah, so it is not the quantity, very important that I'm sleeping for 6 hours or 8 hours. It is not only the quantity, it is also the quality of sleep matters. And so that means your quantity has to be good, quality of the sleep has to be good. That means you should be sleeping within say 8 to 10 minutes. Once you are in bed, you should go to sleep. Then once it should be smooth. That means you don't have frequent awakenings. You have a very good night's sleep where there is a good amount of deep sleep which happens, and there are no arousals, no disturbances, and when you get up in the morning you are fresh. So that's good sleep. One other component of good sleep is also the schedule, because sleep is a cycle. It's a wake sleep cycle, what we call as a body. It's a biological clock, and that has to be regularized. That means you need to have a good schedule. You should be sleeping at a regular time every day and waking up every day at the same time. So that schedule also has to be important. So if you sleep at 2 o'clock at night and then get up at 12 or 10, then you have a good quantity, maybe a quality, but again the rhythm is gone. So that rhythm is equally important.
Like so said, sleep hygiene, I think like we have hand hygiene. Sleep hygiene is equally important through all ages, from I would say infancy to adults. And what do we mean by sleep hygiene? Sleep hygiene is when you have a consistent bedtime and a consistent routine. And the routine can be age dependent, but it has to be a very short, maximum of 20 to 30 minutes routine, where for a child it can be, he can have his dinner, he can go for a bath, change into his night pajamas, read a story and go to bed. But this has to be consistently practiced, and there's no change over weekends. There is no delay of 2-3 hours allowed on weekends. So consistency, I think across all ages is very important, and we need to all practice very good sleep hygienes.
Yeah, you were talking about sleep hygiene, Aarti. Any other points like about media and how do you enforce? I would ask, how would you enforce that the child is having good sleep, like quantity, quality, schedule? Apart from scheduling, any other points you would enforce as a practitioner, sleep practitioner?
So whenever I see children these days, being a sleep specialist, I always ask the sleep history. And you're seeing that many parents say, we come home late. We come home by 9:30. So how does the child sleep early? We don't get time to spend with the child. But parents, you need to understand that the child's sleep cannot be according to your timing. You have to change according to the time of the child. One parent has to come in early, or the grandparent can come in, but the children's timing cannot be depending on your timing. Secondly, I think naps. Till the age of 3 to 4, naps are common. But after the age of 4, if at all a child naps, it should be a short nap of around 30 to 45 minutes and not beyond 3:30 p.m. In older kids, there should be no caffeinated drinks no coffee after 3 p.m., regular exercise, and screen. I think the biggest problem that we are all facing unanimously is screen. And too much of screen delays sleep timing even more. So I think we all need to be very particular about exercise, good food, no caffeinated drinks, and no screen 1 hour before sleep.
And then how much screen time would you allow generally?
So screen time is dependent on age by the IAP guidelines. We say no screen time less than 2 years, 2 to 5, maximum of 1 hour in breaks of 30 minutes each.
Very, very important.
And after that, it is screen time, but only for educative purposes under supervision, which does not disrupt the child's education and sleep.
Do you mean screen time is only not mobile, right? You're talking of TV,
laptops, and if at all you want to do a FaceTime with a family member, I understand. But there can be no gaming, persistent gaming. 1 hour is upper limit. No mobile at least till the age of 12 years. And after that also I would say supervised mobile use.
So having understood the importance of good sleep, having understood that what is good sleep, and I think beautifully explained about the sleep hygiene practices, which I think Aarti has explained. Let me, ask Aarti. Aarti has been practicing as a sleep specialist and coaching many parents about sleep. We'll slightly shift the gears and talk about smaller babies, where I think this sleep hygiene, after 3-4 years, I can understand. But what about newborns, infants, smaller babies, toddlers? Do you face problems during those episodes? I would tell, what about those babies?
So I will be honest, and as a mother, when I had my firstborn, that is around 18 years back, I thought if you're a mother, you ought not to sleep because you cannot coach a child less than 1 year. And so many parents do come that the child doesn't sleep, they can't go to work. But sleep consolidates by the age of 3 months. And we can start coaching as early as 6 months. And I think we all need to educate our parents on the importance of sleep coaching for the child and the parents too. So sleep coaching should begin by 6 months. Many kids, what happens is that there are 2 types of, something is called as a behavioral insomnia in childhood. So that is not a typical insomnia that you see in adults, but you see it in infants and you see it in toddlers. In infants, it is more because of an association. So let me explain that when a child sleeps, we all have a sleep cycle and we have a normal awakenings. So children have a cycle of around 45 to 60 minutes. So they do have 4 to 5 night awakenings at night. We also have an awakening, but we know how to put ourselves back to sleep. But when a baby who's fed to sleep wakes up during a normal awakening, because he has been fed to sleep, he does not know how to put himself back to sleep. And he will need to be fed to put to sleep. So feeding, rocking, walking with the child are all negative sleep associations. So typically we tell parents after the age of 6 months that you can do away with the night feed. So when you put your child to sleep, you keep him in the crib awake but drowsy. You gently sush him to sleep, but you don't rock him, hold him, or feed him. You should dissociate feed with sleeping. So what we advise is you bathe the child, you feed the child, change the diaper, and then come into the room where they sleep and put them in the crib drowsy but awake.
Okay. So I think we get a lot of parents who, the typical story which you said, like the child needs breastfeeding or rocking or maybe some Jula kind of situation. Yes. And then only the child goes to bed. And then when a child is going to bed at 11 o'clock, 12 o'clock, till the father arrives, because that's very common now with the IT parents. And then at every time child gets up, father has to move around or rock him. Yes. So how do we manage such shit?
So again,
we get a lot of
sleep hygiene. You have to calm down, even if the child is a younger kid. By 7 o'clock is a wind down time. Once the child knows the lights are dimmed in the house, there's not too much of noise and disturbance, he knows it's time to go to bed. But out here, things begin at 7 p.m. in our country, and the noise and the older sibling and parents coming in late. And when a child is sleepy, unlike adults, they get more agitated and they find it more difficult to go to sleep. So I think we all need to follow, irrespective of who comes when, the timing of sleep, the schedule of sleep, and no association with sleep after the age of 6 months should be practiced.
Okay, so that means you need to have a fixed schedule, maybe at 8 to 9, maybe slightly later in our country.
8:30.
8:30
Ideally,
for
sir.
infants and
Yeah.
toddlers, and then no associations, and get that negative association out, and then try to console him with some, maybe some tapping and all this. But then, is it okay for the child to sleep in the same bedroom or in the same bed? So that when the baby is around 2 years, 1 year, what is your opinion?
So that's actually also very cultural, honestly, and also room constraints. Now, if you don't have a separate room for the child, then I think don't co-sleep. You can put the child on a mattress down. But ideally, the child should start sleeping in his own room by the age of 2 years. And many parents are very guilty, but don't feel like guilt. It's a good habit. It's good for the child and good for the parents, I feel, in the long run.
You mean to say that co-sleeping is okay? Co-bedding maybe
Yes,
should
yes,
not be
yes,
practiced.
yes.
So you can, the child can sleep in the same room,
Yes.
but same bed sharing
Yes,
should not
should be avoided.
practiced, because that can be other disastrous consequences, like suffocation and all those things can happen. So that's one thing. So, and then you said positive association, negative association. So all the associations like thumb sucking, or the child is getting his favorite toy, that's okay.
We have some positive associations like thumb sucking. That's self-soothing. Something that child does not depend on us to go back to sleep. That the child does on his own. Like, in Western countries they use pacifiers, but you can use your own thumb sucking or a favorite toy or a favorite sheet, which you can use to soothe the child. So there are positive sleep associations. On that note, I would like to ask, sir, what about older kids? This is for the younger ones which have an association problem, but what about school-age children? Do they have different issues with insomnia, behavioral insomnia of childhood?
So they have a lot of bedtime resistance. Like they would. I think the parents here would watching this session would acknowledge that many times they would they have a bedtime resistance. They don't want to go to sleep. So they will say one more story, mama, one more story, something like that, or one more song. So they keep doing this. So they are trying to prolong their sleep time. So I think sometimes you have to discipline this and tell him, okay, it's 9 o'clock and now you have to go to bed. So you may start the bedtime slightly early, the routine which we have been discussing. Maybe start at 8:30, but then 1 or 2 stories or any other bedtime routine which you are following. And then sometimes you have to be really very disciplined, sometimes stern, and say, okay, no, now nothing more. So this is the problem which we encounter, which is a typical bedtime resistance. And then of course, even negative associations can happen. And then sometimes awakenings because of certain issues which we will be discussing.
Like sir said, that 2 to 5 years old, they test limits in every way. So they test our limits even for sleep. But as parents, we have to be very, very, certain things are non-negotiable, like sleep timings. And that has to be done it's consistency. If you don't, 2 days of no consistency will get you back 10 steps in sleep hygiene. So daily consistency is very important. And older kids, you can do it with like a token economy or a sticker or a chart to make it more interesting for them. As a positive reinforcement concept in behavior.
So I mean, you mean to say if you start coaching early, maybe 6 months or so, then these problems will be less?
So I think in India we need to make aware of something called a bedtime routine, because I see most patients don't have the concept yet. Schedules, yes.
So as a pediatrician also, I think we should start discussing about their sleep.
So, yes.
And I think parents also need to talk about their sleep when they go to the pediatrician, when they go for the routine vaccination growth. They should be talking about sleep with their pediatrician.
Absolutely, I think sleep is very important. And again, another thing that comes commonly in OPD, so many parents say that my child snores when he has a cold, but he continues to snore even if he doesn't have a cold. So is snoring normal in children?
So snoring is something which is common, and I would say it is almost to the tune of 8 to 10% in children and adults. We need to identify whether this snoring is normal or abnormal. If that snoring is happening very frequently, maybe 3 to 4 times a week, then it becomes an habitual snoring. And now we need to understand whether this is just a part of the normal behavior or normal process, or there is some abnormality going on. Why does snoring occur is important to understand. So there is some Snoring indicates that there is a noise which is produced when the child is breathing, and that noise is indicating that there is some obstruction to the flow of air, and therefore child snores. Do you want me to tell when?
So I think we would like to let the audience know there's something called even pathological causes of snoring in children.
So then if the child is snoring and otherwise his child sleep is good, he is absolutely having a regular sleep, he is fresh in the morning, there are no awakenings, then probably it may be just an habitual snoring, which is common. But 1% of these children, so 10% of those who snore, would have something which is known as obstructive sleep apnea. Now, what is for the parents? I think it is not the diagnosis to be made, but we need to look at some red flags and the signs which are telling that this snoring is something beyond normal snoring. So, if there are anything like we have discussed that is frequently getting there is awakening when he is get up in the morning, he is not fresh, he is sleeping during daytime, he is irritable during daytime, that means his sleep is disturbed because of snoring, and he is regularly getting up because the sleep is not good. Very extreme state would be the child is not able to breathe, he gets up, gasps for breath and go back to sleep, asking for water and all those things. So that means he has an obstruction which is becoming severe and severe, and that is when I think before that you need to consult your doctor. So the point for parents to note is, even if you feel that the child is snoring and it is familial, you need to tell your pediatrician that my child snores, because then let the pediatrician decide whether this child's snoring is normal or there is something more to it. He will examine, he will ask you more questions, and you will find out whether there is some more thing need to be.
So do we have any tests to diagnose childhood OSA, and what are the basic treatment protocols, if any?
Yeah, so obstructive sleep apnea or abnormal snoring is because one is of course habitual snoring, which may be normal and nothing abnormal is there. But if there are any such problems like daytime symptoms or nighttime abnormalities, the child is restless, he's sleeping in the prone position, he's getting up frequently, then that means there is something wrong, some breathing issues are there happening during sleep, and which we call as sleep disorder breathing or breathing disorders during sleep. And the commonest investigation, which as a pediatrician, is of course the history. We need to ask these questions to the parents, which the pediatrician would do. Beyond that, parents can help us by giving us a video clip of the when the child is sleeping, how does he snore, how does he sleep when he is gasping. So this audio recording also helps us. Pulse oximetry during sleep during frequent pulse oximetry at bedtime and later on, parents can give that input. But the gold standard, of course, most of these parents, if they are giving some positive history, then we assess. We also take help of ENT colleague to look at the size of the adenoids. The commonest cause is adenoid tonsillar hypertrophy. That is a common problem. Obesity is another reason why the children would snore and they have problems. And then there are certain complex problems like genetic syndromes, for example, Down syndrome child, and there are genetic syndromes where the snoring is definitely abnormal. So what we do, we first assess, evaluate, examine, and then sometimes take an ENT opinion also. If there are tonsils and adenoids which are big and the child is otherwise healthy, many times they need tonsilloadenotomy and the child is okay.
So do you have an investigation? When I tell parents about OSA, they're like, oh, children can also have OSA. So is there any way do we do any studies in children if it's not adenoids, do we do anything else too?
Yeah. So the first step is ENT evaluation and total assessment and maybe audiovisual recording. But if there are complex issues, as we have discussed, obesity, or if the tonsil adenoids are not really big and still the OSA or obstructive symptoms are there, then we do sleep study, which is done in Jehangir Hospital, and there are other centers where this sleep study is done. So even in children, we do sleep study where the basic idea is the child sleeps in the hospital, we apply some electrodes, get a lot of information, how he is sleeping, what is his oxygen, what is his CO2, what is his respiration, how is he breathing, and then we collect a lot of data, and then we evaluate that and interpret that, and then we guide the parents. So that's sleep study.
So that I think we all have that's why we talk so much about sleep. Sleep is not just what we think of, but it can have too many issues as well. So again, another thing is many parents say that they in the clinic they have a 2-year-old who comes and he suddenly gets up at night and he starts crying and he's difficult to console, and the parent says he's awake but not consolable and they cry. Or sometimes we have a parent with an older kid who says sleepwalking. So what are these? Are they a part of sleep issues as well in children?
Yes, so these are sleep issues, but fortunately, most of them are benign sleep issues. So I think most of the parents would come across this situation in younger children where the child would suddenly get up, start crying, howling, he's irritable, he's not recognizing parents, his eyes are awake but he's not recognizing. So these are confusional arousals. What you need to just do is you need to be calm and try to try to take him to the bed, but don't do too much of, don't try to help the baby too much. Just try to see that the baby remains in the bed and help him to soothe. Too much of any aggressive handling may further agitate the baby. Sometimes you have night walking. Again it is common, normal, benign, and you need to focus on sleep hygiene as well as try to see that the safety is maintained, because your doors, your windows, all those things, because sleepwalking can have disastrous consequences. But otherwise this will go on for some time and would resolve, and you focus on sleep hygiene and see that the media overuse and all other issues are not there, because that could be one of the precipitating factors. But most of the time you don't have to give any medications, but talk to your pediatrician, talk to the specialist, and they would help you.
So these are all parasomnias which are not dangerous, but yes, they settle on their own. Basically, no intervention is needed.
But do you come across are there any dangerous parasomnias or dangerous things which look like parasomnia? Aarti,
sometimes you have like a night terror or bad nightmares. There also night terrors are more in the early part of your sleep. When the child is screaming, it's very troublesome to see. But again, that parasomnia is nothing very scary about it, but no long-term consequences. Many parents are scared that they're screaming. Are they something during the day has happened to them or something? Are they thinking something? But it's just nothing to worry about. It's normal.
And sometimes like abnormal movements also are normal, but
like a restless leg syndrome,
restless
you have restless sleep, and that also is picked up in your polysomnography as well if needed.
Yes. But then parasomnias are normal, but sometimes convulsions can come at night.
That's why it's important to differentiate the two, and that's when a video is very helpful. And in case we're not sure, then we refer to a neurologist and do an EEG to differentiate the two in that case.
And then now switching the gears again, Aarti, you also deal with a lot of adolescent issues, and you of course practice sleep. So then adolescent is a different ballgame and very difficult to handle. So yesterday I saw a girl who is like 15 years, 16 years. She's sleeping at 2 o'clock at night, and she has to get up at 7 o'clock because her school is the college is in the morning. So then, do you see such patients, and how common is it?
So all the time, and like I said, my son is in the 12th, and all his friends and everyone, we're only discussing sleep because nobody wants to sleep. And unfortunately, we have to understand that adolescent is a phase when there's a massive overall in the brain in terms of pruning. Why? Because memory, emotional regulation, all happens during sleep, like you said, sir. And physically, you have the immune system working, hormones interplay, muscle strengthening. So a lot of physical and mental changes happening during adolescent. And on top of that, adolescent is a time when your sleep timings are naturally delayed because of that. So we normally sleep by 8:30. Suddenly adolescent says, I don't want to sleep till 10, 11. But that's a normal part. But unfortunately, our school timings are 7 a.m. So they have to get up early. And when I ask most parents that how much do you think is enough for an adolescent, they tell me 7 hours. But no, even our adolescents need 8.5 hours to 9.5 hours of sleep on a routine basis. Secondly, screen. There's so much of screen. Every class is online. They're either online chatting with their friends or studying or whatever. Screen delays sleep. And thirdly, I tell all adolescents when they come to the clinic that when you study, you basically say that you can't sleep early because you're studying. But you think of your brain like a computer. When you're studying, the memory goes and stays in a part of the brain called the hippocampus, which is like a USB stick. It's short-term memory. But when you sleep, it is moved to the higher centers, and there it is consolidated. So if adolescents, you're not going to sleep, you're not going to free the space to learn new things, and nor are you consolidating your memory. So less sleep is not going to do any good to you all. So I guess if you sleep more, you'll study the same topic faster.
Oh, that's very interesting to know that adolescents do have a slight physiological delay related to hormones. So they would naturally would feel sleepy by 10 to 11, not forcing them to sleep at 9 o'clock probably not
Not
work.
going to
But
work.
then 2 o'clock is okay, because then how does it get complicated? I think there is a physiological delay, and
Yes,
the
so
other
that's
point.
circadian rhythm disturbances. Physiological delay compounded by the screen,
Yeah.
compounded by the stress
Caffeine.
of 10th, 11th, 12th academic pressure
And caffeine.
and caffeine, and it's multifactorial.
Okay.
So I think it's not their fault. I feel bad for the adolescents, but somewhere I think as pediatricians and parents, we need to tell them that chronic sleep deprivation will have take a huge toll on them mentally and physically. And that I think if we explain to them, that they will understand more. But just telling them don't sleep, sleep early, they're not going to listen.
So that means again here comes the role of the sleep hygiene.
Yes.
So it may not be 9 o'clock, but around 10 to 11 should
Yes.
be their sleep.
And I tell them calculate, you need 8.5 hours. So they are the best, you calculate the amount of
Go
sleep.
back. Okay.
And if at all they need to nap, they cannot be napping more than 30 minutes.
Okay.
And ideally before 3:30, because again that will delay their sleep longer, the timing of sleep at night.
So I think basic things what Aarti is telling us is even in adolescent have a fixed schedule, which should not be varied, because we have adolescents who would sleep few hours or say 4 to 6 hours during weekdays and then 10 to 12 hours at
Yes.
weekends, which is again probably not.
It's a social jet lag. So we can't have a social jet
Okay.
lag. Many people say, नहीं, but Saturday, Sunday को वो 12 बजे उठता है.
Yeah, that's not allowed, right?
But that is not acceptable.
That's not acceptable, because consistency again is the key. Regular rhythm is important, and you need to have some fixed schedule, maybe 10 o'clock, 11 o'clock, whenever he is feeling sleepy. And then, of course, no caffeine, no naps, and media, of course.
Yes.
And then I think so that's how you work
Yes,
with
we
them.
understand it's
But then
difficult.
adolescents, do they listen? All
So,
this?
but I have seen that if you tell them that how it affects their memory, their emotions, their overall obesity, it causes so many long-term repercussions, they do understand. And then for girls, I tell them beauty sleep is true. You want that good hair and good skin, then you need to sleep as well. But I think the key is to explain them the importance of sleep. And I think parents need to understand, because I think even parents are lacking sleep, sir. Isn't it true?
Yeah, true. So then so in beginning the important point, so we talked about sleep in children. Adults, are there any long-term effects in adults on sleep?
It's the same. As we see physical, like they can be disease, like more chance of heart disease, you have more chance of obesity, more chance of negative emotions, more stress hormone release. So it's the same across. I think even adults need to be counseled about sleep these days.
Apart from this memory, learning, and irritability, in adults, I think it is cardiovascular risk,
Yes.
diabetes. all
Huge
this.
risk, cancer, they say,
Yeah.
inflammatory conditions more.
So I think we were talking about biological clock. So it's not only the hippocampus or the hypothalamus. Every cell in your body has a clock, and if your clock is disturbed, then your metabolism gets disturbed, and then of course your diabetes, hypertension, and other parameters
Absolutely.
they are going to get disturbed, and then it is difficult to control. So sleep becomes an important part of not only children but also I think the adults
Absolutely.
management as well, and we need to focus in those. So it is always physiological, like in adolescents we say that physiological because he's not going to sleep at 11. But there are certain children, after doing all this like sleep hygiene, we have worked up on the caffeine, media, still they are not able to, and sometimes they say, no, I get sleep at 3 o'clock and then I get up at 12 o'clock. And if they are allowed to sleep properly, then they have a good sleep. So is this a disorder or something?
Yes, so then if even after practicing good sleep hygiene and taking care of everything, they still cannot sleep, then yes, it is a pathological disorder called circadian rhythm disorders or delayed sleep-wake phase disorders.
Okay.
And in that case, I think you need to take your adolescent to the sleep specialist to investigate further.
Okay.
And also, like, so what do you like to say about excessive daytime sleepiness? Something about that as well.
So excessive daytime sleepiness is, whatever we have talked about, I think it compounds or it may result in excessive daytime sleepiness. So excessive daytime sleepiness will occur if first thing is if you are sleep deprived, right? So for whatever reason, because of the most of the time it is poor sleep hygiene, very rarely circadian rhythm disorder which you have just mentioned, and sometimes related to drugs or anxiety, depression. You are not getting good sleep, and then you are feeling sleepy during the day. Second issue which we have just discussed, obstructive sleep apnea. If you are not getting good sleep at night, obstructive sleep apnea or parasomnias, bad parasomnias, you are frequently awakening, that quality is not good.
Yes.
And then again you will feel lethargy. Lastly, rarely, sometimes you may have hypersomnolence because of the neurological problems. That's rare, but again, bring it to the notice of the pediatrician that whether it is sleep deprivation, whether it is the quality of the sleep which is abnormal, or whether it is a true hypersomnolence where you feel sleepy despite of having good sleep at night. So that's the domain of a pediatrician and a neurologist, and that's not a very common problem. If you focus on sleep hygiene and snoring and other issues, I think most of the things would
And
get
I
tackled.
also, one thing I've said, many kids, they're labeled as hyper or irritable in school.
Yeah.
Take a sleep issue, because it could be even just a simple sleep deprivation, and they're labeled, sir. So I think even that is very important for parents.
So many children with attention deficit.
Yes,
needs.
yes, yes.
So the sleep hygiene becomes again an important issue.
Now, because sir is a pediatric pulmonologist, I would like to ask, sir, in this season, sir, with so much of flu, so many allergies, asthmas, so what sleep is compromised? So any tips on parents to help with that?
So I think these are medical conditions where the sleep gets affected, not because sleep hygiene is not affected, because the sleep hygiene has been taken care, sleep routine is established, but children would get up, they have sneezing, they have asthma, allergic rhinitis. So again, this history is very crucial, and taking him to the pediatrician and talking about those medical conditions and treating them properly would again help you to have a good sleep. And sleep is the first thing which also gets affected during those episodes.
And so I think we've covered nearly everything about sleep. That we have a few questions. Somebody's asked that can sleepwalking be considered disorder? I think you answered that. It's not.
It's not a disorder. Sleepwalking is basically a type of parasomnia which occurs usually during the first half of sleep. And here, and there is a strong, many times family history. So there is a strong family history. So it usually occurs between children of 6 to 12 years, sometimes even in adults. And here your focus is of course on sleep hygiene, less media use, and good sleep routine. And second thing which also I think need to focus is safety. Safety of the bedroom, safety of the the windows, the doors, the stairs, because that is the only problem which may happen during sleepwalking. But otherwise it is a benign condition, usually goes with time. But bring it to the notice of the pediatrician. Very, very few people may need something more or some more medications.
We have another question, sir. What is sleep weaning in babies? And I think she means to say sleep coaching. What is sleep weaning?
I mean, probably sleep coaching, there's nothing on a sleep weaning, but sleep coaching, of course, I think Aarti has already focused that the duration of sleep gradually gets down.
Yes.
So initially it may be 18 to 12 hours, 20 hours, then by 1 year it is around 12 hours, by 5 years it is around 10 to 12 hours, and then it goes down. So second concept, I think weaning mean napping. Napping is very important and very useful in first 5 years of life. It is useful again for the same reason, consolidation. But after 5 years, napping is usually physiologically not required. Maybe a 15 to 20 minutes of resting or napping may be okay. But physiologically, if your child is sleeping more than half an hour during daytime, then it could be daytime sleepiness. And it could be meaning that your child is actually not getting good night's sleep. So that could be one of the ways to wean the child off gradually.
I think you have another question. Is sleep apnea reversible?
Yeah, so sleep apnea is, I think, obstructive sleep apnea, and obstructive sleep apnea is reversible and treatable. Reversible in the sense it is treatable, and most common cause is obstructive sleep apnea is adenotonsillar hypertrophy in children, which many times need removal. Once you remove that, I think the healthy child, most of the time it would be reversible. In obese children, it is a slightly different or difficult situation. Adenoids, if they are there, we remove them, but weight management, that is diet, exercise, media, lifestyle management also becomes an important cornerstone of their management. So yes, And then some few children, it may persist despite of all these interventions, which are complex OSA, which are basically your symptomic conditions, where sometimes we may have to give them support, CPAP or BiPAP machine at night. But there are very, very few children who would go on that.
Sleep apnea has to be looked into and it's very much treatable. That's the lesson that we would like to say. The message out is that even if whatever the reason be, it has to be treated because, sir, what happens if you don't sleep? Treat a sleep apnea appropriately.
Yeah, that's what I think Aarti has already told us, that apnea means your oxygenation has gone down and the child is not able to breathe. The oxygen has gone down. That means all the consequences of poor sleep are going to be manifested. So your irritability, daytime sleepiness, learning, memory, all that. And then of course in adults we have already said the cardiovascular and other conditions. So sleep apnea is one of the commonest sleep disorder which we see, apart from the common issues which we have spoken. And please mention snoring and sleep apnea related issues to your pediatrician. He would definitely help you.
I think we need to really give a lot of importance, and going back to previous time when sleep was so important. Now sleep has been taken over by gadgets and late nights and a lot of pressure on children. But I think we really need to talk about sleep early on, right from infancy to adolescence in our clinics. And Dr. Bafna and myself, we do run a pediatric sleep clinic in Jehangir under the Paediatric Pulmonology department, and we'll be happy to help if anyone needs it. So anything that you would like to say before we end?
So that's great. I think
another question is there? I just have a look. It's not coming. So what treatment should we take for cognitive behavioral therapy for insomnia? So, well, cognitive behavioral therapy or CBT is a very good behavioral therapy when I think it will help if we are having insomnia in adolescents typically, which is more to do with anxiety, stress and exam fears. And when you do CBT on such children, you basically help elevate the anxiety and that will help them sleep better. So I think CBT does have a role in our adolescents who have a lot of stress and anxiety. Sir.
Yeah, so insomnia, they come to you with insomnia.
So they're stressed of an exam, they feel they study more, they don't want to sleep. That perpetuates less sleep. And because of stress, they don't get sleep. So in our times, sometimes we don't get sleep before an exam. But CBT is basically cognitive behavioral therapy. It trains you to make your thoughts in a better way so that you know that not sleeping is not going to help and stressing is not going to help as well. So it just helps you sleep better because you self-talk yourself into reducing your anxiety.
Yeah. So behavioral therapy, so do you take help of medication sometimes in this? Rarely?
The medications I think is the absolute last resort. Don't take over-the-counter sleeping pills at all because it disturbs the architecture of sleep. So, and it also causes a lot of drowsiness the next day. So I would say no over-the-counter medicines. Anything else? So would you like to add a note on melatonin? Because many adolescents do ask about the use of melatonin these days.
That's why I think melatonin is a drug which is normally secreted in your body and which makes you sleepy at night. So it is basically stimulated when there is a darkness. The pineal gland will secrete that. When you are awake, there sunlight would inhibit that. So melatonin is used very, very, very rarely by sleep specialists, particularly in complex insomnias like autistic children, sometimes ADHD children. But in general, melatonin is no, and there are other therapies which we have discussed, and we need to know why a child is not sleeping rather than going for a shortcut like taking melatonin. So you need to know the underlying problem.
And I think so, like for everybody, for adolescents and adults, wind down time. They can avoid screens, yoga, mindfulness, meditation. All of these practices really help.
Physical activity, I think, is important.
Exercise, exercise for physical and for mental also calming down and winding down. Yoga, you have so many yogas and meditation these days which are helping. You have sleep apps also on phones which help you sleep on time these days.
So I think with that, thank you so much, Aarti. What we have discussed so far is sleep hygiene. I think is crucial. Sleep forms an important part of your life. Give due importance not only for children but for yourself also. and practice sleep hygiene, sleep coaching at very early age. Snoring is never normal, in the sense, let pediatrician decide whether this is normal or not normal, and give the details and make it a practice to discuss sleep with your pediatrician. And I think that's all from my side. Aarti would want to add.
We all need to give importance to sleep, and I think parents need to take care of their sleep and be role models too. That's my only advice. Thank you so much.
Thank you so much. Thank you. And if there are any questions later also, we would like to help you. I think Aarti has already said that we have a sleep center here, and we would be more than happy to help you and your child. Thank you so much.
Thank you.